So, today we're going to look at the diagnosis of developmental and neurocognitive disorders. Obviously, we're not going to be able to cover all of the disorders that are in the DSM, so I'm hoping that you're reading all the corresponding chapters and really pulling a lot of information on your own. I'm really just going to be hitting the highlights of some of the more common ones that you're going to see when you're working in the field. We're going to talk about autism spectrum disorder, ADHD, both pediatric and adult, and we're also going to look at different causes of dementia. You can see dementia in young people if they've had some sort of vascular episode that stopped blood flow to the brain or a traumatic brain injury or something like an overdose. So we want to look at that and make sure that we're providing the scope of services that's necessary. And then at the end, there's this mystery diagnosis, really just to put all of these big thoughts and ideas at work. Later in the semester, we're also going to look at oppositional defiant and conduct disorders. You're going to notice some overlapping symptoms with ADHD. So try to remember this lecture in a couple weeks when we look at those, because a lot of times clinicians will get this kind of confused when they're making the diagnosis, especially if they're not working with children a lot. So, for autism spectrum disorders, it includes persistent deficits in social communication and social interaction across multiple contexts, as manifested by deficits in social emotional reciprocity. So, reduced sharing of interests or emotions or affect, failure to initiate or respond to social interactions. And one of the keys of diagnosing autism spectrum disorders is that you can't use the same behavior to represent multiple things. So, if you have a child who doesn't choose to speak, they're just not communicative at all, you can't use that one symptom to qualify them under both deficits in social emotional reciprocity and in nonverbal communicative behaviors. So we want to make sure that we're looking for a variety of symptoms and they're really matching with all the criteria needed through multiple symptoms, not just one thing fitting all the boxes. Deficits in nonverbal communicative behaviors could look like very poorly integrated verbal and nonverbal communication. This is especially true for people with autism. You might see abnormalities in eye contact and body language, lack of facial expressions, and nonverbal communication, as maybe with people with fetal alcohol spectrum disorder, which is not an autism spectrum disorder right now in the DSM. But remember, it's still in areas for further study. But people with FASD, as well as people with autism spectrum, you may also see misunderstandings of gestures and nonverbal behavior and deficits in developing, maintaining, and understanding relationships, ranging from difficulties in sharing imaginative play or making friends or just a lack of interest in peers. And so this also sounds a little bit like schizoid personality disorder. So we want to rule that out. And this is where I'm talking about of all of these things kind of can just bleed together, making a fast diagnosis really isn't benefiting anybody. We want to look at all of the symptomology together and see the full picture of the client. I do also want to pay special attention to the pediatric post traumatic stress disorder. If a child has been exposed to pediatric PTSD, and that begins at the age of 6 or under, the child's been exposed to some sort of trauma and it develops PTSD, they may have failure to initiate or to respond to social or emotional interactions. They may have just been completely withdrawn from themselves, have a lack of facial expressions, they may be sort of flat and disengaged, and they may have an absence of interest in their peers. They just don't trust them. The world is a scary place. It's an awful place. They're depressed, they're angry. So, whatever we're looking at, we want to make sure of what we're dealing with. We want to rule out any trauma history that might be confounding our diagnosis. We're also looking for restricted and repetitive patterns of behavior, interests, or activities, so stereotyped or repetitive motor activities or use of objects or speech, such as lining up toys or flipping objects. Some people have things lined up just so, or they may do something called stemming, where they are going to repeat a particular movement over and over again. They may have idiosyncratic phrases that they say, and they might just say the same things all the time, like, yep, 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 or that's the way it is, that's the way it is. Um, So this would be very different than my filler word of when I'm presenting to you. Is not an example of one of those. An instance on sameness and inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior, which produces extreme distress at small changes and difficulties with transitions, rigid thinking patterns. I'm right now thinking about my friend's son, who tends to be more of a judger on the Myers-Briggs scale. He really likes structure. Remember one day he went into preschool and they have circle time first thing in the morning, and they would greet each other and they would read a story, and it was circle time at 8 o'clock every morning. And that morning it was somebody's birthday, and he went into the classroom and he sat down on the circle and he was ready for circle time. And the teacher called him over and she said, "We're not doing that today. We've got a birthday today." And he was just beside himself. He's like, "No, it's 8 o'clock. It's circle time." And he just sat his happy little self on the circle. And eventually his teacher was like, "Well, if you want to join us, you can." So does he have autism? No, he likes routine. And it didn't cause him extreme distress. He was just like, "Well, I can do that now and I can do circle time after." So we look at children who are much more structured, like my friend's son who really needs or cherishes their routines. But if they're disrupted from them, it's the end of the world. For a person with ASD, we're probably looking at somebody who's experiencing extreme distress that throws themselves into a tizzy at small changes. They're highly restricted, fixated interests that are abnormal in intensity or focused. And again, you've got some kids out there and some adults who may develop an interest in one area and they're just fixated on that, and they will know everything there is to know about that. Does that mean that there's a problem? No, it could just mean that they're really into this one particular topic. And a lot of people go through phases. I know I do. When I decide that I'm really interested in something, I'll order every book I can find on Amazon or go to the library and get every book I can find on it to learn everything that there is about it. Like I started juicing and I got a top of the line countertop juicer. I bought all these organic fruits and veggies. I brought a fresh juice to work every day for a month. And then, it was just a lot of juice, so I stopped. Is that abnormal? No, but what we're looking at is this a part of a constellation where a person has one interest and they're not interested in anything else? I still had other interests. I could break away from it. But there are a lot of people who really just throw themselves into something and are hyper or hypo reactive to sensory input. And so there was this kid that used to come into the daycare center at the gym that I worked out at. And when he experienced too much stimulation, he would become extremely distressed. And so the sensory input, if there were too many kids or too many things going on, if there was too much noise, it was more than he could take. And it would cause him a lot of distress. So you can talk about sensory input in terms of smells, sight, noise, whatever. We're looking at the environment of the person. What do we need to address in that person's environment to help them feel as grounded as possible? And then you can also have hyporeactivity, whereas there may be loud noises and the child doesn't startle, or there might be really noxious smells and they don't even seem to notice. So, on the other end of the spectrum, we're looking at wanting to take a look at the symptoms that must be present in an early developmental period, but might not become fully manifested until social demands exceed limited capacities. So, depending on where they are on the spectrum, it's important to realize that you may have children that aren't presenting as like they're meeting this kind of criteria. It's not causing them any sort of psychosocial impairment, so parents aren't bringing them in. And they're not saying, something's wrong, something's going on to the point of whatever their capacities are. They have to be stretched to the limit sometimes to even notice that these things are present. So it could be kindergarten, it could be first grade, it could be generally by first grade, usually. There's a huge transition for children, especially in the public school, when they go from kindergarten, where they've got a lot of freedom, a lot of play, a lot less structure, to first grade, when they're sitting at a table and they're expected to be learning. And it's extraordinarily structured. A lot of children have difficulty with that transition. And if you've got a child who has other issues with changing structure, making friends, that sort of thing, you might see things become more problematic when they switch over to first grade. The problems that the person is experiencing may be masked by learning strategies later in life. So, you may have an adult who was diagnosed with autism spectrum disorder when they were a child. Does that mean it went away? No. They learned how to deal with it. There are a lot of people who can develop skills to figure out how to accommodate their unique characteristics. So, as clinicians, those are the things that we can help people do, help them figure out how to integrate into the mainstream to the extent that they choose. And I'm going to say this again, to the extent that they choose, because it's their treatment plan, it's not ours. Maybe they aren't interested in making a ton of friends. Okay. If it's not causing them problems with that particular symptom, it's not problematic. We can address that at a later date if they want. So the symptoms have to cause clinically significant impairment in social, occupational, or other important areas of functioning. They're not better explained by intellectual disability or global developmental delay. So we want to look at that too. If you've got a child who may have been a preemie and may have been exposed to things in utero, or who you expect for any reason of intellectual disability or developmental delay, then you see that child maybe not rolling over quite when they should. You want to take a look at what's going on, because early intervention services are available in every state, often covered by Medicare and Medicaid, in order to help children who have developmental delays to get them off to the right start. So you can Google early intervention services for children if a parent is bringing this to your attention in session. So I'm just going to share another example. My nephew, he's 4 now, and when he was just about 2, he still wasn't really speaking like he should. He wasn't really doing more than 2-word sentences at that point. And his dad, my brother, he was starting to get a little freaked out and brought him to his doctor for a checkup and told the doctor, he doesn't speak in full sentences. He's not meeting the criteria in any of the baby books. And the pediatrician told my brother, well, because you're getting his needs met. And my brother was like, oh, yeah, yeah, obviously I'm getting his needs met. He's like, well, as soon as he needs something that's not getting met, he'll speak. And sure enough, as soon as he enrolled my nephew in preschool and the attention was being divided between him and 10 other kids in the room, he had to learn how to ask for help and he started talking. And so we want to take into consideration all of the factors that are going on when making a diagnosis. Is there a reason that this child is not engaging or not making friends? Maybe they have 6 other siblings at home and don't really have an interest in making friends outside of their immediate family. Or maybe they've always got a friend with them at the park, so, they don't really need another one. So we want to normalize as much as possible and determine what's causing things. Individuals with the established criteria for autism, Asperger's, or pervasive developmental disorder, not otherwise specified, are now all lumped under the DSM 5 underneath the category of autism spectrum disorders. So you can argue whether or not that was a good idea, but right now, it is what it is. So if you've got a client who meets criteria for what we used to diagnose as Asperger's, they will fall under the autism spectrum disorder now. It's important for us clinicians to really understand the depth and the breadth of the different symptoms in the spectrum now, because it's not broken out in different segments like it used to be. Individual who have deficits in social communication, but whose symptoms don't otherwise meet criteria for autism spectrum disorder, should be evaluated for social communication disorder. So, most of their issues have to do with interpersonal communication. Then we want to take a look at the social communication disorder. And as I said, you want to avoid using the same behavior to satisfy 2 criteria or more. For example, if somebody repetitively puts their hands over their ears, you could consider that a repetitive motor movement when they get stressed, or it could be considered a hyperreaction to stimuli if things are too loud or too high pitched. I know for me, certain pitches bother me a lot more than others. High pitched sounds, especially my husband whistling, drives me bonkers, but low pitched sounds don't bother me as much. Maybe it's really more about my husband than it is about pitches, but regardless, you can't count the behavior for both criteria. So we want to look at this as a hyperreaction to stimuli, or are we going to consider it a repetitive motion? One example of a specific criterion might not be sufficient to assign the criterion as being present. So, for example, if the child puts their hands over their ears when they're at daycare, do they walk around like this the whole time when they're at school? It might be the noise from the particular environment. So we want to look, is their behavior clearly atypical? Is the noise bothering other children or not? And is it across multiple contexts or does it only occur in one context? Is it happening at home, at the grocery store, at the park, and at other places that look similar, like a room with 20 other children? My experience with adults is there tends to be an underdiagnosis of ADHD in people who are not diagnosed as children, and they can be maybe end up being diagnosed with bipolar disorder instead. Work in substance use treatment and see a lot of co-occurring diagnoses. People will come in and they'll basically have been self-medicating as best as they could with the substances they were using. So we want to take a look if somebody's using substances, especially if it's stimulants or amphetamines, and sometimes they're using other medication or substances like marijuana to help them focus a little bit better because they just feel all over the place. But for children, there need to be six or more of the symptoms, five for adolescents or adults, that have persisted for at least 6 months in two or more settings to a degree that's inconsistent with developmental level. And that's a lot of things, a lot of conditions that we need to consider. And we have to look for the pervasiveness. Is it only at work? Is it only at home? Is it only in one place or is it happening across the board everywhere where this person is engaging? Symptoms don't occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder, specifically mood disorder. So, this is where the messy crossover of diagnoses can again start to happen. We have difficulty concentrating, difficulty focusing in some mood disorders. You can have some symptoms of hyperactivity and hypomania as well as mania. What if they're intoxicated with a substance? Is that what's causing the symptoms, or could it be withdrawal from a substance? So, what we're really looking at is inattention. Failure to give close attention to details or making careless mistakes or in work or with other activities, has trouble holding attention on tasks or play activities. And this one, again, similar to what we're talking about with autism spectrum disorders, people with ADHD can have hyperfocus, especially if there's one particular thing that really interests them. They may get lost in it. Sometimes they'll actually gravitate towards that thing when they're feeling overwhelmed because there's so much stimuli, they'll gravitate towards that because it's the one thing they can focus on and kind of block everything else out. People with ADHD have difficulty filtering out and deciding which stimuli are important to pay attention to, and they tend to notice a lot more things. They might be hearing the traffic outside, the birds chirping, the fluorescent lights humming, their neighbor chewing gum, and feeling the texture of their clothes on their skin. Maybe their shoes are too tight, they're hungry, their stomach's rumbling, all while the teacher is lecturing. They have difficulty narrowing the field and focusing in on just one thing. They'll have attention on everything. Okay, so again, we can see why this is overwhelming and why you might have difficulty getting something done. If you're looking at the lights and you're looking at the sound of the person at the same time, instead of thinking about it as inattention, we might think about it as people with ADHD have a dysregulated attentional system. Sometimes it's inattention, sometimes it's hyperfocus. So we don't want to rule people out again just because they have something that they can get completely immersed in, even if it's a video game and they don't seem to listen when being spoken to directly. A lot of children, they'll hear it and it just kind of goes in one ear and out the other, and you're like, did you even hear what I said? Um, Often does not follow through on instructions, fails to finish schoolwork, chores, or duties in the workplace because they lose focus and they get sidetracked. Now, this is really easy for children who are gifted as well because their mind is constantly working and disorganized with time management problems. Again, something that's uncommon in children who are gifted, but we also see it in other conditions that cause people to be more disorganized, often avoids, dislikes, or is reluctant to do tasks that require mental effort over a long period of time. Now, this is a little bit more unique to ADHD or mood disorders. Remember how hard it is when people are depressed and have high anxiety to focus and get sustained mental focus on something. So they may kind of avoid doing these things because they think it's just going to be a losing proposition. They often lose things They often lose things necessary for tasks and activities like school materials, wallets, keys, eyeglasses, and phone. Just this week, I've already lost my keys, my laptop charger, and my phone. And so, again, we want to look at whether this is normative or is it worse than normal. And for developmental age, I definitely shouldn't be losing these things so frequently. We can help people develop strategies for not losing things in their houses. So, for example, I have this table right by my front door when you walk in, and it's where I put my keys and my purse, and I take off my shoes there. It's this whole routine. And so I know where those things are. But the other day I came home and my dog was barking and my routine was disruptive. I put my keys by her dog bowl and I forgot all about it. I wasn't being mindful or paying attention in the moment. That's not necessarily a symptom of anything except that I was a little bit distracted, which is normal, especially when you have a dog that's been home alone all day. Distractibility, as I said, people with ADHD can get easily distracted not only by external stimuli, but by their own thoughts and forgetfulness. If you've got all that stuff going on and coming in, and if you've ever volunteered in a preschool classroom, you can kind of get a feel for what I'm talking about. You've got 17 kids running around wanting different things from you, and you're like, okay, I'll get you that, and I'll get you a juice, and you need a new crayon, and I'll take you to the bathroom, and I'll do this. And you start doing one thing, and you can't remember the three other things, or maybe you forgot all of them. So it's not uncommon. So think about somebody with ADHD who's constantly got all of that stimuli coming in, and they're trying to figure out what to remember and what not to remember because their brain doesn't focus filter out the stuff that the stuff is not as important. So they're basically trying to manually filter out all of the stimuli, going, I need to remember this, I don't need to remember that, I need to remember this, I don't need to remember that. And the other criteria that we're looking at is hyperactivity. And we want to differentiate it from impulsivity, such as we would see in hypomania, often fidgets with or taps hands or feet or squirms. And see, this can also be a sign of anxiety. May leave their seat in situations when remaining seated is expected. Again, this can be, especially with children, can be anxiety, it can be boredom, it can be that they're gifted. People who are gifted tend to move a little bit more, um, runs or climbs in situations where it's not appropriate. However, adolescents or adults have gotten it so under control a little bit more, and maybe this comes out as feeling restless. They're just like, oh, I can't stand waiting in line. I can't stand waiting in traffic. They get really restless if they have to be still for any period of time. And maybe as an adult, they figured out some life hacks to not have to wait. Maybe they show up late after the lines die down so they don't have to wait. They're unable to play or take part in leisure activities quietly. These people are just always on the go. And it doesn't mean that they're always talking, it can mean that they're moving and doing things and making noise. They're often driven as if by a motor. So, like a little energizer bunny, it's constantly going and going and going. They may talk excessively, and this is especially problematic with interpersonal relationships when the person blurts out an answer before a question has been completed or finishes somebody else's sentence because they have difficulty waiting their turn. And these are two things to consider, especially in treatment centers. When you're doing group therapy, that can be really problematic to the functioning of the group if somebody has difficulty doing that. Their group can take that as the person dismissing their opinions or not taking them seriously. It can feel invalidating where the person really, didn't mean to be rude. They just don't have the impulse control there. So we need to help them figure out how to develop skills not to finish other people's sentences, not talk over or interrupt people, and they may interrupt or intrude on others, butting into conversations or games, just kind of walking up and taking over a conversation. So that's one of those behavioral things that we can really help with. Common errors that we're looking at when diagnosing ADHD is, like I said, differentiating between bipolar and hypomanic or a manic episode. And ADD, ADHD mood swings are generally a response to something that's happening in a person's life, and it matches the person's perception of that trigger. So something happens that makes them angry. Their mood swing is going to be angry and it makes sense. It might just be a little bit excessive, but it makes sense. So we want to look at whether there was a precipitating trigger and can they shift instantaneously. So they may go from being angry or upset and then back to, okay, I'm good. So you're not going to see that in somebody with a manic episode. it's going to be more of an ADHD mood swing. It's going to go away very quickly, and that person with ADHD becomes engaged in something new or interesting. So, one thing that parents with children with ADHD can do is if they're older and they get upset about something, they can learn to redirect their attention and get involved in something else so they can kind of create some distance from that precipitating trigger. Sleep issues, racing thoughts, restlessness can be caused by hypomania, mania, anxiety, or even sleep apnea. So we want to rule those out if they're not getting good sleep, if they have some restlessness. When people have sleep apnea, they often wake up multiple times during the night. So we may confuse that with restlessness. They have difficulty completing projects. We want to rule out any learning disabilities or dyslexia or something like that, or obsessive compulsive personality disorder. Remember, people with obsessive compulsive personality disorder often don't finish projects because they want it to be perfect and they never reach perfection. And then it might turn into something if they have an anxiety disorder, if they're afraid of evaluation, or if they have PTSD. One thing that helps differentiate, I read ADHD distractions are often happy thoughts. Uh, they're not often distracted by something that makes them angry. A lot of times they'll be distracted by a pretty bird. So my brother was diagnosed with ADHD when we were young, and I remember it was just always a struggle to be sitting next to him while we were both trying to do homework at the kitchen table. He was always facing so that he was looking out the window into our backyard, and he used to get so distracted watching the birds and the squirrels outside. And so finally, my mom had him sit in a different seat facing towards the inside of the house when he was doing study time because otherwise he just wouldn't get anything done. His mind would just kind of always migrate over to the window if that view was available to him. Social awkwardness and difficulty reading social cues can be a sign of autism spectrum disorders, and unusual interests and overfixation and interrupting and talking to and interrupting and talking over people can also be a symptom of autism spectrum disorder. So we kind of want to rule those out as well. So we want to look at the whole gamut. And remember, like I said, ADHD is not technically part of this autism spectrum disorder, but we've talked about it enough for you to be a little bit familiar and think, okay, there might be something going on with this person or adult or child. Um, you know, where were they exposed to alcohol in utero? That might be causing some of these, and it just hasn't been diagnosed yet. These diagnoses aren't made quickly in the span of 1 hour evaluation. There's usually copious amount of assessments, interviews, testing, a lot of other ways to get other people involved in this diagnosis to help gather information and rule out other possible diagnoses. So there's a lot of considerations for ADHD that you can read about in your DSM, but I did want to call your attention to the difference in presentation between males and females. What, off the top of your head, might be some of the differences? This is a cultural consideration to think of. Gender and sex is definitely a part of cultural consideration. So oftentimes diagnoses will look different between men and women, and this is one that's an example of that. ADHD is more predominantly diagnosed in boys. It's not that common in girls. It's often undiagnosed or underdiagnosed in girls. So, a study in 2006 looked at a group of girls and found that girls with ADHD were viewed more negatively by their peers and seen as having more issues with social interaction. They were more forgetful. Maybe they forgot to call their friends back. And so, you can see this playing a role in the social connectivity piece of it. All the politics in middle school and high school friendships, they might not have a ton of close friends because of this. They're more likely to be depressed. And so by adolescence, often eating disorders or substance abuse was also present to self medicate. We're more likely to diagnose girls with anxiety and depression, not ADHD. And so, they never really get better because we're not treating the whole picture, we're just treating parts of it. And thinking about, social media right now, each time I open Instagram or TikTok, I'm seeing these videos about ADHD symptoms, and the creators like, oh, I didn't know I had this until now. And I think it's really cool that mental health is coming to the forefront of our focus and being normalized at the same time. But I'm cautious as these are quite literally influencers influencing the way in which our kids are perceiving the world. Taking one symptom out of context does not create a diagnosis, but these things are pretty cool to consider since talking about it and normalizing it is a great step towards acceptance and treatment. The Canadian Journal of Psychiatry last year in 2022 found the top 100 most viewed and liked ADHD posts on TikTok. Of them, about half of them contained misleading information. The bulk of these videos made it seem like certain symptoms associated with psychiatric disorders, including anxiety, depression, anger, relationship conflicts, dissociation, and mood swings, were specific only to ADHD. So, kind of think about that next time you're scrolling. So, traumatic brain injury, vascular neurocognitive disorders, it's anything that causes the brain not to receive blood and oxygen for a period of time. So, that might be strangulation, or we can see that in instances where somebody's been victimized. We can see it in instances of autoerotic asphyxiation. We can even see that if somebody overdoses on central nervous system depressants and their heart stops for too long of a period of time. We see it in neurocognitive disorder in people with HIV. So HIV does affect the brain, and we see it as you would expect in Alzheimer's. Dementia and Alzheimer's is obviously diagnosed later in life. With Alzheimer's, a person has difficulty completing familiar tasks, difficulty determining time or place. They often misplace items, have difficulty making decisions. They may withdraw socially and have mood or personality changes. So, why is it important to know this if you don't typically see older populations? Well, because Alzheimer's can have an early onset. So if you start seeing some of these symptoms popping up in your clients, it's because the earlier somebody gets in for treatment, the better their prognosis. Some of the medications and treatments now are showing efficacy at slowing the progression of the disease. They're not able to reverse or stop it, but if people get on meds early, they can have a much longer period when they're still independent. Lewy bodies and Parkinson's. Lewy bodies can occur by themselves without Parkinson's disorder, or you can have Lewy bodies in someone with Parkinson's disease. Lewy bodies are not reversible and it's not treatable, but people can see specialists to treat their symptoms and give them the highest quality of life possible. So, one of the first symptoms we'll see is visual hallucinations, and you might start seeing movement disorders, tremors, shaking, tics, or regulation of body functions such as their heart rate, their temperature, cognitive problems, sleep difficulties, fluctuating attention, depression, and apathy. Now, the ones like cognitive problems, sleep difficulties, fluctuating attention, depression, apathy, and even hallucinations to an extent could be present in someone with major depressive disorder with psychotic features if you have hallucinations there. So, we don't just want to assume that it's major depressive disorder. If you have someone starting to show these kind of symptoms, especially with visual hallucinations, they probably need to be referred for an evaluation so they can be managed and maintain their highest quality of life. Um, I just had a client at my agency with a history of severe depression and a history of methamphetamine use, and he reported some new visual hallucinations. He said he was seeing ghosts in his house. And so we did a lot of work together with our psychiatrist for assessment and eventually got him to the hospital for some brain scans because, what is this? What could this be? We were thinking, is it the new depression medications that he was on? Is it a relapse on the meth? Or is it just ghosts? Is he really just seeing ghosts? Because, here's our cultural consideration. Do some cultures believe in seeing and communing with spirits? Because his did. Is it neurocognitive? Spoiler alert, it was neurocognitive. And we were really only able to get to this diagnosis with the help of multiple professionals and because he had a great relationship with his counselor and told her about the ghosts that he was seeing. And Huntington's disease, we'll talk about, is a progressive fatal disease. So, we're not going to spend a lot of time on it because it's hereditary. So, people who develop it generally know that they have a chance of developing it, and they're probably going to come in going, yeah, I know what could be going on here with me. So your work as a counselor won't necessarily be as a diagnostic detective, but more existential therapeutic in nature. The onset is typically in the 30s or 40s, but it can be before age 20. It causes progressive breakdown and degeneration in nerve cells in the brain. And the period from the emergence of the symptoms to death is about 10 to 30 years. So, people that we're working with who have become symptomatic for Huntington's disease will be dealing with a lot of grief and existential issues, as well as long term care planning and those sorts of things. The symptoms, mood symptoms, are similar to depression, and maybe there also is additional depressive symptoms present, which would be expected when you've just discovered that there's a shortened lifespan to your life. The cognitive symptoms are representative of dementia with the addition of difficulties with impulse control. So, there are things that you kind of want to look for with Huntington's disease. Like I said, if somebody comes into your office and they've got it, they probably know they have it, or at least they know they have a relative who had it. And hopefully, the family understands it's transmitted through generations. You want to work on building social support, maybe through support groups or with their friend group. So, time for a mystery diagnosis to really put all of this into perspective. What would you diagnose if you had an adolescent come into your office, say who was angry and irritable, tended to get bored easily and be restless, maybe overexcitable, but is underachieving, just not making the grades that you would expect for them to do in school because they seem to be really bright? They may have some peer issues, spending large amounts of time alone, excessively high expectations of others, and a lack of a sense of belonging. So they really just feel like they're a square peg in a round hole. They may engage in power struggles with adults. So I'm thinking about, maybe oppositional defiant, but okay, they have a lot of perfectionism and they put a lot of pressure on themselves and get stressed out because they want everything to be perfect. Their judgment often lags behind in their intellect. They may be really smart, but then, oh my gosh, how could you forget to do that? And they may suffer from something called reactive hypoglycemia, which is after they do something really intense, they have a glycemic episode. So, reactive hypoglycemia is kind of a monkey wrench in the works that we haven't talked about yet. But for the rest of them, thinking about what would you diagnose if this youth came in with these symptoms or the majority of these symptoms? If you work with children and adolescents, this is definitely something we're thinking about for helping to differentially diagnose ADHD, Asperger's, autism, and giftedness, because there are a lot of symptoms of giftedness which overlap with the diagnostic criteria. So that was a little hint in there. So, all of these symptoms are symptoms of giftedness. So, let's think about why this might be anger and irritability. What if you had to go to a training and you really didn't want to go? And when you went, it was dreadfully boring and you just had 17 other things that you could be doing, but you had to go to that same training every single day for the rest of your life. For children who are gifted, sometimes that's what school's like. They get finished with everything so quickly or they learn it so quickly and they've got to sit and wait for everybody to catch up, and they find it tedious and they start getting restless and they can get sort of agitated, which they can lead them to, like, how many of the famous really smart people in the past underachieved in school because they got really bored and just didn't try. Underachievement is not always the case, but it's not uncommon for the child or adolescent or even adult who isn't feeling challenged, and they may not really give a lot of attention. Peer issues with someone who is gifted, is, maybe there are times that you've gone to a party and you've been talking to somebody and they seem to talk so slowly and you're just like, come on, give me what you're saying, get to the point. And for someone with giftedness, a lot of times their mind runs faster than everybody else. So they get frustrated and irritable spending time with their peers, especially. So they may spend more time alone. They may spend a lot of time talking to themselves. You can see it in adults. They may also prefer environments that are either working in isolation, like working in a lab or working on a computer, or working with other gifted people. But they're really going to struggle with people of average intelligence just because They don't feel like everybody. The world might seem like it's going in slow motion, which can lead to this sense of, maybe they're not feeling like they belong so much. They don't get along with anybody at work, or, they don't like participating in things. And they also have excessively high expectations of others. They have difficulty understanding how they differ from the rest of the world. They see something that's so easy, and I don't know why you have a problem with it. Um, it might be really hard for them to do some group work. Power struggle. Someone who is gifted may see multiple different avenues. They also tend to like to argue and play devil's advocate because it stimulates their mind. It's not because they're trying to be oppositional, but they want to see the other side of it. They can be very much type A personalities, but not always. Their judgment lags behind intellect. So you'll see, especially in teenagers, because as this person gets older, the judgment and intellect gap closes. But when they're teenagers, there's a lot of problems with judgment, going to school and forgetting their schoolwork at home, or going out with friends and doing something that just showed like really poor judgment. They're really smart, but they got caught up in the peer pressure of doing things. So if somebody seemingly is showing poor judgment in the choices they're making, but they're really bright, and you're like, how could you even think that was a good idea? You're going to think this might be a symptom of giftedness. And how can we help people stop and use their thoughts in order to analyze the situation and make better judgments? Now, the reactive hypoglycemia is interesting because we didn't talk about it yet, but the human brain uses a ton of glucose. And so the human brain of the person who is gifted works even faster than the rest of us. What they've seen in studies that they've done with people who are gifted, especially after a period of concentration on something, is they might start getting irritable and tired and sluggish just because they're experiencing hypoglycemia. Their brain just burned through all of that blood glucose. So, youth who have reactive hypoglycemia tended to do better when they had a healthy snack, a moderate protein carbohydrate snack at like 10 a.m., and then maybe like think after school at like 2 p.m. between the meals to keep the blood sugar staying more stable. So, watch for a reduction in behavior problems when your kids have some nuts, some cheese, some apples in their bellies. Also, we're thinking about, as a counselor in the field, are you seeing kids that have that sort of midday energy slump? Are you experiencing that? What can you do within your agency to make sure that you have enough fuel to create the brain energy that you need? Um, at the end of this module, I'm going to link to a video that's a clip of a larger presentation, but we'll talk more about the gifted child and the issues arising in behavior and co-occurring diagnoses. If you don't ever watch the video, just know that when we're talking about gifted, we're not talking about the 3% at the tail end of the bell curve. We're actually talking about the children who are anywhere in the top 10% of students, but like 90 to 100% percentile. So that's who we're talking about. So children who we would normally think are really intelligent, but maybe we wouldn't normally qualify them as gifted, so to speak. They don't meet all those criteria. They will often have many of these symptoms, like we talked about. So you want to rule out giftedness, which is not a diagnosis per se. But if the child is gifted, they're going to have to learn strategies to cope with that throughout their lives. And this is where the clinicians can come in handy, helping them figure out how to deal with the situations when they start to feel restless, how to attenuate their anger and irritability. They have to sit in boring meetings or whatever it is that tends to make them more irritable. One thing some of my clients do is they'll bring a notepad with them wherever they go. And if they're in a meeting and it starts to go too slowly, they can write, they can draw, they could doodle. This is something that I encourage in group therapy too. Just doodle away. And this is true in every sort of scenario. But if they have something to do that interests them, it helps a lot. If they're able to bring a mobile device, like if they're riding on a long bus ride or a plane where they're going and they get bored really quick, will also help to hold their attention. So many of the disorders of childhood represent endpoints on a continuum. There's just like these other diagnoses, there's normal and then there's abnormal. And then with children, we have to say, is this normal for the developmental age? So, what is normal for a child who is 8 obviously is not going to be appropriate for a child who is 16. We need to remember and differentiate pediatric PTSD from autism. So, if we're looking at a child who has trauma issues, we want to make sure that that's stabilized before we look at other issues. We want to differentiate giftedness from disruptive mood dysregulation. If we're seeing an adult who does not appear to have significant deficits, that just means they had really good interventions when they were growing up and they learned how to deal with their unique characteristics. When you're making the diagnosis, especially in autism, you want to avoid using the exact same behavioral example to satisfy two criteria. One example of a criterion is not sufficient to say it's present, especially if it's only present in one setting. So we want to look across multiple settings. That's regardless of our diagnosis. For dementia, if we're looking at vascular dementia, if we're looking at autism spectrum disorders, if we're looking at even depression, we're looking at, does it exist across settings at home, at school, at work? People with ADHD have hyperfocus, just something that they're really interested in. And this can actually be used creatively as an intervention for that person with ADHD who tends to start feeling overwhelmed if they have something that they can gravitate towards and get hyper focused on for 30 minutes. And then maybe they have a timer that goes off that will kind of jolt them out of that focus and get them kind of moving in a more grounded way. You can also use guided meditation and a variety of other things. If someone is experiencing depressive type symptoms, you may suspect depression with psychotic features. You want to rule out Lewy bodies, especially if that person is experiencing visual hallucinations. So make sure not to miss giftedness if it's there too. Look at the child's IQ. If you have access to that, if you have access to school records, talk to their parents, their teachers, see how they're presenting in their verbal interactions as a child who's really, really bright, but maybe not thriving in the school environment for some reason. And don't assume that the gifted child has it made and it's just all going to work out. That's not something that happens if they're feeling like a square peg in a round hole. Yes, they're really bright, but in order to merge with mainstream culture, they need to develop some tools to deal with their own unique characteristics. They're not necessarily going to just work it out on their own. So we need to help them embrace their gifts and figure out how to develop relationships that are meaningful and work in a way that helps them achieve what's important to them in their lives. So, really dig into the DSM and read more about these if you haven't already. Look for prevalence rates, cultural considerations, pay special attention to those differential diagnosis pieces. I try to make my courses reflect real world scenarios. So, memorizing all of the diagnostic criteria just isn't a real world thing. You will have access to the DSM at work and at school. So, don't feel like you have to memorize it. It's just a tool for your reference. What I do hope that you get from these lectures is clarity on what you're reading about and some examples that will help you think about the material differently. As always, let me know if you have any questions.